in the helix? Looks like we do. Would you
Yeah,
like me to go ahead and get started?
I think so, Jeff. Yeah.
All right. Well, as Associate Section Chief in Abdominal Imaging, it is my great pleasure to introduce Dr. Kennedy, although I think she needs much in way of introduction to all of us. For those of you that are not aware, Dr. Kennedy is a director of ultrasound and has been fulfilling that role for many years now. She is a fellow of the Society of Radiologists in Ultrasound, Society of Radiologists in Ultrasound, or SRU, forgive me, and a passionate advocate of all things ultrasound within abdominal imaging. And I will turn the time over to her to introduce our guest speaker.
So David Fetzer is a fellow of the Society of Radiologists in Ultrasound, and he's the medical director of ultrasound in UT Southwestern and the Parkland Health and Hospital System. To give you an example of how good he is, he was awarded a Rising Star Award as a faculty in 2019, and that exemplifies people with enthusiasm, commitment, professionalism, and leadership. He also directs something called Cactus, which I have to read because I can't remember, and it is the Collaborative for Advanced Clinical Techniques in Ultrasound for clinical and image-guided research. And if you look up his PubMed publications, unlike Paula and myself, who tend to hang out in the pelvis, he bounces from pharyngeal muscles to the liver and back again. I'm delighted to introduce him to talk about advances in ultrasound for chronic liver disease, because I do confess that my eyes tend to roll to the back of my head when I get to the 10th or 15th, abnormal LFTs, look for fatty liver case. So I'm interested to learn from what David has to share with us. And he is going to touch a little bit on contrast and ultrasound. He actually runs one of the busiest contrast enhanced ultrasound labs in the United States. And one of the things I love most about him is that he's younger. He's the next generation or two down from me, but he is a passionate advocate for ultrasound and abdominal imaging. And he knows and will demonstrate to you that ultrasound is so much more than just a scout view for an MRI or a modality to do a biopsy with. So also, he's going to touch on LIRADS. And I know that we don't use LIRADS because we use the OPTN system, but for our residents and fellows going out into the real world, LIRADS, ORADS, and these other systems are bread and butter in many practices, so it behooves you to learn about it. My previous Grand Rounds invitee, Gane, was introduced as the fabulous Fernanda Pazir. Moving on now, I give you the ferocious Fetzer to tell us all about ultrasound in chronic liver disease.
Well, thank you, Dr. Kennedy, for that amazing introduction. I hope I live up to those warm words and those standards. And it is my deep pleasure to be here virtually to present to you several topics that I'm very passionate about that all involve the liver and chronic liver disease. So I do have a few mandatory disclosures. But as Dr. Kennedy alluded to, I'm a huge advocate and member of several LIRADS committees, including on the steering committee, as well as involved in several committees on quantitative imaging, particularly in the liver. So we're going to be talking about several of these topics throughout the talk. So my goals will be a whirlwind tour through the liver, starting briefly with the use of ultrasound in HCC surveillance and diagnosis, which is where LIRADS will come in. Discuss some of the emerging techniques for liver fat quantification. This is an area of active research, especially in my lab. Emphasize the utility of ultrasound elastography and fibrosis assessment. Put it all together with some case studies and highlight some future opportunities. So as Dr. Kennedy alluded to, we do ultrasound all the time for elevated LFTs or suspected acute liver diseases, and that won't necessarily be a focus of this talk other than some case studies at the end. However, fatty liver disease, which we see almost every day, and in fact, some of my students and residents and fellows here think when they see a normal liver, they can actually see the portal triads. They call it starry sky because they see so much fatty liver. So that's actually quite important and a big component of this talk. And of course, ultrasound is a vital tool in the assessment of chronic liver disease, the detection and diagnosis of cirrhosis, and screening and surveillance for HCC. So to basically let everyone know again about LIRADS, it is one of the many RAD systems supported by the ACR. And for those who may gravitate toward OPTN, do know that with the latest revision, OPTN is going to defer to LIRADS for the diagnosis of HCC. So OPTN and LIRADS will be in sync with their final diagnosis of definitive HCC. And moving on from there, LIRADS will be the imaging system of choice. That has already occurred for AASLD. So AASLD now also advocates for the use of LIRADS. This is very similar in VIRADS and ORADS, where other societies have adopted the leadership and the research and the quality initiatives initiated by these various systems through the ACR. So it has been a huge benefit for me to be an advocate for LIRADS here and abroad. And the use of our template reporting has allowed me to retrospectively analyze hundreds of thousands of studies and link those to outcomes without having to open a single imaging study. So, a uniform lexicon, structured reporting, and image-centered reporting and recommendations has been a huge benefit in our system, and hopefully your system as well. So this is the current LIRAD ecosystem, or as it was in 2013, but there have been several recent additions and changes. For one, we're now in version 2 of the LIRAD ultrasound surveillance algorithm, now called version 2024, and also just released a few weeks ago is the contrast-enhanced ultrasound non-radiation based treatment response algorithm, or TRA, version 2024. Now, we won't have time to talk about that, but we will talk about ultrasound surveillance. And the overview here is just like in CT/MRI, we have applied LIRADS in at-risk patients, so patients with cirrhosis, or most patients with hepatitis B. And for ultrasound surveillance LIRADS, we assign 2 scores. One is an ultrasound category, 1, 2, or 3, and then a visualization score, A, B, and C. To talk about the visualization score, this is was kind of a nebulous system when we first created it about 4 or 5 years ago, but it is now altering patient management. As you can kind of guess, visualization A is you see almost all the liver. You're pretty confident you'd be able to exclude an HCC. Visualization B, there may be some moderate limitations where you may be missing small but clinically insignificant masses, and then hepatitis. And then visualization C, severe limitations. And these, we do encounter these patients where they're big swaths of the liver we just can't visualize for various reasons. And evidence now shows that for visualization C patients, those could be considered ultrasound failures. And those are the patients that may benefit the most from alternative screening strategies such as abbreviated MRI. We just don't have the resources to do MRI and CT in every patient at risk for HCC. So we're really getting to a point where we're doing patient-specific modality choices and correlating that with serum tests like alpha-fetoprotein to do more patient-centric screening and surveillance, with majority of patients still qualifying for ultrasound surveillance. The category 1, 2, and 3 is broken up like this. Obviously good visualization, no observations worrisome for HCC. So if you have patients with classic focal fat sparing or previously diagnosed lesions such as a small hemangioma, these are all categorized as 1, and they continue on 6-month surveillance. Ultrasound 2 subthreshold, and again, with our modern ultrasound units and high resolution transducers, we pick up these sub-centimeter nodules all the time. There's now plenty of research to show that very few of these are clinically significant. They should not go on to contrast-enhanced imaging. They should continue on ultrasound surveillance every 3 to 6 months. And after about 2 periods of time when they're considered stable, they can go back to ultrasound 1 category. Again, until they reach a centimeter or larger, they should not go on to contrast-enhanced imaging. However, now we have lesions in the liver in an at-risk patient that are a centimeter or larger, and they can be isoechoic, hyperechoic, or hypoechoic. It doesn't really matter. Obviously, these are all suspicious for HCC and should go on to contrast-enhanced imaging. Importantly, contrast-enhanced ultrasound is one of the advocated modalities, even for AASLD. If we go back to our ecosystem here at the bottom left, contrast-enhanced ultrasound is now one of the diagnostic modalities for HCC. The flow diagram and the diagnostic table look very similar to CT and MRI LIRADs, with categories going from CEUS LR1 to CEUS LR5. And this is just an example from our core document showing a lesion 3.4 centimeters with arterial phase hyperenhancement and mild late washout. And this gets you to a CEUS LR5, which has the same specificity for HCC as CT and MRI. And that's been shown through multiple studies, including a multi-site trial just published from the United States, of which UT Southwestern was a member. So this is a recent case from my clinic. So this was a patient with hepatitis B and C, came through, had a 3-centimeter isoechoic observation in the left lobe of liver. It's categorized as US3 positive. And we actually, same day, started an IV and immediately did a contrast-enhanced ultrasound, which showed arterial phase hyperenhancement, mild and late washout. And so this is a definitively HCC with over 95% specificity. I was able to call up the HCC clinic and get this patient into clinic within a week for management of his newly diagnosed HCC. So that's about all I'm going to do talking about LIRADs, because I know there may be some advocates and opponents of those systems. So let's go on to something we can kind of all agree on, and that's the imaging of chronic liver disease. And we all now know that fatty liver disease is the #1 cause of new chronic liver disease cases in the United States. And why is that? Well, there's a general conception that steatotic liver disease is precipitated by this 2-hit model. One is some kind of metabolic derangement. And on imaging, we can see other manifestations of that, like abundance of visceral fat or fatty replacement of the pancreas. And in these situations, you have a lot of free fatty acids as well as adipocytokines that circulate and accumulate in the liver. Now, this without inflammation is kind of what we call simple steatosis. If you have a second hit, however, that could be genetic predisposition, superimposed alcohol use, superimposed biohepatitis, et cetera, then you actually set up lipotoxicity and lipoapoptosis, creating that inflammation and the reparative process of fibrosis deposition that is paramount of all of these chronic liver diseases. And what's the new nomenclature? So as of January 2023, AASLD came out with some new terms. So it's no longer fatty liver disease, it's now steatotic liver disease. And as we know, it used to be NAFLD and NASH. Those terms have been removed from their lexicon, and it's now MASLD, metabolic dysfunction associated steatotic liver disease, and then MASH, metabolic dysfunction associated steatohepatitis. So just so you know, you're going to start seeing these terms in the hepatology literature as well as in from new radiology literature. Of course, you can have superimposed alcoholic liver disease and drug-induced liver injury and other processes that can manifest as steatotic liver disease, but of course, the most common is going to be MASLD and MASH. And what is the burden of disease here in the United States? Well, assuming we have over 330 million people, a third of those are going to have MASLD. So 100 million people in the United States in the general population have steatotic liver disease. 6% of the total population, or 20 million people, have MASH. And even though it's only a small percentage, 3% have at-risk MASH, meaning they're progressing toward cirrhosis. That's still 5 to 10 million people here in the United States. And it's not just the United States. It is a worldwide problem, with one estimate of being of over 1.6 billion people with steatotic liver disease. So why is liver fat quantification so important? Well, as Dr. Kennedy said, the clinical presentation is nonspecific. Often it's just mild LFT elevation. It is very, very common. We see it in the reading room every day, all day. But quantifying that fat can actually improve your diagnostic confidence, because sometimes you can't really tell. Is it just the abdominal wall attenuation? Is it something else going on? So I think it's helpful in boosting your confidence. But you could also think of liver fat quantification in screening and surveillance modes. So for screening, you're taking at-risk patients, you're identifying liver fat, and you're either counseling that patient lifestyle modifications, giving them a medication, say Ozempic, or enrolling them in a clinical trial. And this is important because MASLD and MASH are a major cause of liver-specific morbidity and mortality, and are associated with other adverse outcomes like heart attack and stroke. Now, for surveillance, you've instituted your intervention, but now you're bringing them back and seeing if the patient is unchanged, has improved, or has worsened. And this is incredibly important because a reduction in liver fat is associated with improved outcomes. There are emerging therapies where reduction in liver fat are actually a biomarker for treatment response. And in fact, just a few weeks ago, resmetirom here was just released, and this is a MASH-specific pharmaceutical. So we're going to start seeing, just like we've seen with Ozempic and others, commercials for this medication for patients that actually have been diagnosed with MASH. So I do think that identifying these patients, providing them a baseline, and then tracking them over time are going to become part of our daily practice. Because the historical gold standard was calculating the NAFLD activity score, but this required a biopsy. And there's no way we can do a biopsy in 100 million people in the US every year or so to see if they're getting better or worse in developing MASH and at-risk MASH. So that's why imaging quantification is so important. You know, we can identify this opportunistically by CT, and there's a lot of great literature for the use of CT in identifying patients who are unsuspected. Obviously, MRI, everyone agrees, is the imaging standard of choice. I'm not here to advocate that ultrasound is going to replace MRI, because obviously the biochemical proof of separating water-associated hydrogens from fat-associated hydrogens and biochemically calculating a fat fraction, PDFF, is, I think, still going to become the reference standard. However, does ultrasound have a role to play in this disease process? And I obviously am here to say yes. Now, we all should know by now the general grayscale features of a fatty liver, and that's increase in echogenicity. We obviously teach our trainees here, you have to have an internal reference because echogenicity is all relative. You can dial it up or down. So we usually correlate it with, say, the right kidney, and we'll come back to that in a minute. Increased attenuation, that's from absorption and scatter from liver fat, so you can't see the back part of the liver. And obviously areas of focal fatty sparing around the gallbladder or big vessels, that's a very specific finding. And if you take all these findings together, ultrasound actually performs very well for identifying moderate to severe steatosis with a positive predictive value of 93%. But it does not perform well with mild steatosis. And of course, it's very difficult to use these signs longitudinally to see if a patient is improving or worsening. So there was a big initiative started probably about 4 or 5 years ago by RSNA Kiva, the Quantitative Imaging Biomarker Alliance, to develop a new biomarker committee called PECUS, the Pulse Echo Quantification Ultrasound Biomarker Committee, with a goal of studying 3 different biomarkers: attenuation, backscatter, and speed of sound, to apply them for liver fat quantification. So I'm a co-chair in this biomarker committee. I'm very excited that we're making quite a lot of progress in developing a phantom model of the liver fat and testing out new algorithms, because the sound interaction within the liver is actually fairly well modeled, and we know that liver fat has several influences on quantifiable acoustic parameters, such as the attenuation, which increases, speed of sound, which decreases, and backscatter, which increases. So let's step through this, and starting with a speed of sound. So obviously we know that sound speed has a constant velocity in tissues depending on that tissue property. You know, we assume 1540 meters per second for our image reconstruction, but if the sound speed increases or decreases, then your echolocalization is disrupted, your image quality is disrupted, and you have a blurry image, such as the blurry diaphragm shown in subfigure D there. And liver fat decreases speed of sound. So when you have patients like this, so screen left is a patient without significant liver fat by MRI-PDFF, and screen right is a patient with severe steatosis by MRI-PDFF. And as you can see, there's a lot of image clutter and image blurring on screen right. This actually may be misdiagnosed as cirrhosis because it looks coarse and heterogeneous, but this is actually a manifestation of poor beam forming and disrupted image reconstruction because of the influences of liver fat on sound speed. So there's actually several techniques for measuring speed of sound in tissues. There's a focusing technique, a spatial coherence technique, and a compounding technique. I won't go into the physics of these predominantly because they're above my head, but keep in mind that there are already some vendors that have sound speed tools already built in. Here's kind of the range of sound speeds we expect in the liver. Normal liver is about 1560. With steatotic liver, it can get down to almost 1400 meters per second. The problem is that when you have superimposed fibrosis or cirrhosis, sound speed increases. So if you have superimposed fat and fibrosis, those are confounding factors for each other for using sound speed as a biomarker. So I believe that another biomarker is going to be needed. But keep in mind that there are several manufacturers out there that provide sound speed. So again, normal patient left with a sound speed of 1548 meters per second, and then a fatty liver screen right with a sound speed of nearly 1500. All right, going on to attenuation. So this is the reduction in the amplitude of acoustic energy traveling into a tissue the deeper it goes. And attenuation is affected by acoustic absorption as well as scattering. And fat increases both absorption and backscatter. So attenuation is actually a very useful feature in liver fat quantification. We see this from darkening of you see this as manifesting as darkening of the posterior deep parts of the liver. So in the normal patient screen left, using a general frequency mode, you can see nice homogeneous image, superficial to deep. But even in the penetration mode with the TGC adjusted, you still have this darkening of the hepatic parenchyma from near field to far field, and that is from the accentuated attenuation from the lipid in the hepatocytes. Now keep in mind that our colleagues in hepatology that have FibroScan, this point of care ultrasound device, now also produces a measure of attenuation called CAP, controlled attenuation parameter. They report this in decibels per meter, and their literature is all over the place with how well this works. I won't go into the details or the politics of this measure and its use in hepatology, but just know that there are hepatologists out there who have very differing opinions about the utility and performance of CAP in liver fat quantification. Now in diagnostic ultrasound, we use the attenuation coefficient, or the AC, and it is the rate of amplitude loss as a function of frequency as you go deeper into tissues. So its units are in decibels per centimeter per megahertz, and the range is from 0.4 to 1.2 decibels per centimeter per megahertz. And there are several vendors that have implementations of this already, and there are confounders that we're starting to learn about and research. One is the reverberation artifact from the liver capsule. One is depth dependency, and we're still looking into the influences of superimposed fibrosis, inflammation, or even a recent meal. So again, there are several methods for measuring attenuation coefficient. There's the spectral shift, so measuring the acoustic spectra at two different depths and seeing how that peak of the spectra changes at different depths, but most of them, most vendors use a spectral difference calculation, which looks at all the frequencies and how those frequencies shift down at different depths, or some manufacturers use a combination of these. But you do have to correct for obviously the TGC, the depth, and other artifacts. So there's a lot of mathematics that goes into trying to create a linear best fit curve to this amplitude loss, and then produce usually a color map of the attenuation rate. And so here are just some examples of attenuation imaging on several clinical systems that are now available. They come in different names, of course. Every manufacturer has to have a special name. So you have attenuation quantification from one vendor, TAI, or tissue attenuation imaging, from another vendor, and then another vendor, UGAP, ultrasound guided attenuation parameter. But as you can see, they're all measuring or they're all providing numbers in units of decibels per centimeter per megahertz. And the final quantitative technique that we're researching is backscatter. And this is the reflection of acoustic energy back to the transducer due to diffuse scatterers. So this is distinct from a specular reflector, or a linear surface that produces a bright linear echo. So this is the acoustic energy that's used to create your B mode image. So if you see in my diagram screen right, you'll see the different echogenicity of the liver parenchyma, and that speckle, bright or dark speckle, is from that diffuse backscatter. It's from acoustic energy interacting with and coming back to the transducer from subresolvable scatters, so literally the cellular level. And so fat increases backscatter. As you can think about it, all those hepatocytes are full of lipid-filled vacuoles that are great scatterers, diffuse scatterers, and so the acoustic energy coming back to the transducer increases. But that's very tough to see by standard B mode images. If you just looked at these two images and told me which liver is brighter, you would probably tell me screen left, the normal patient. But that's because there's a different gain on these systems, there's a different transducer being used, et cetera. So settings and transducer types can alter just the general brightness of tissue. So as we alluded to earlier, you can use an internal standard like the kidney. And so this briefly developed a hepatorenal index, where you actually look at the echogenicity difference between the kidney and the adjacent liver and calculate a ratio, in this case about 0.8. And that ratio tells you something about the relative echogenicity of the liver. You want to target the upper pole, of course, the cortex only, because you don't want to accidentally include a medullary pyramid, which is usually darker than the cortex. And at the same depth, because of course echogenicity is depth dependent. And so these are just some patients from a research study we're doing on these techniques. So we have a normal, a patient without liver fat on screen left, and a patient with moderate steatosis screen right. And you can see the HRI, or hepatorenal index, differences listed there. So the normal range goes from 1.2 to 2.2 generally. The performance literature is all over the place. It is nice that it's a continuous scale, and it does perform better than just a subjective assessment. However, it assumes a normal kidney, right, obviously, and we're still unable to differentiate normal from mild steatosis utilizing this technique. And unfortunately, there's no cutoff values. So this was transiently used in hepatology, but it's rarely used in radiology. We're advocating for quantification of backscatter signal in this very strange units of 1 over centimeters per radian. And that's basically how much acoustic energy is coming back from a conical volume transmitted into and received back from the body. It has a wide range, which is great because we can tease out slight differences in liver steatosis if there's a shift from 4 to 2600, 1 over centimeters per radian. So that's one benefit. However, this is a very challenging calculation with a lot of potential confounders, a lot of potential assumptions. So it is quite resource intensive. There has been some literature to correlate this with MRI PDFF with area under the curve of 0.98, which is great for identifying even mild steatosis. Now, several vendors are coming out with attenuation corrected backscatter calculations. This vendor calls it UDFF, ultrasound derived fat fraction, and it actually is modeled to predict MRI PDFF. So here they're not using biopsy as a reference standard, they're actually using MRI as a reference standard. and predicting MRI-PDFF based off of attenuation and backscatter. So here you see a UDFF of 3%, which in theory would mean a MR-PDFF of 3%. And in fact, we're doing some research on this technique here. We're enrolling patients that have had an MRI-PDFF, and here's just some examples from our experience. Patient screen left with MRI-PDFF of 1 to 2%, and UDFF calculated as 3%. And then here's a patient with 26% PDFF and UDFF 19%. So this is very, very exciting for population health reasons. There's been a couple other publications on the performance of this technique with a very high repeatability and correlation with MRI-PDFF. And then a recent study in obese patients from one of my friends and colleagues, Dr. Dillman, also looking at interclass correlation and correlation with PDFF, showing very, very high performance with an area under the curve of 0.9 for detecting any fats. So that's PDFF greater than 5.5%. So I think that is really, really exciting. So going back to chronic liver disease, we talked about steatotic liver disease, but of course, any chronic liver disease can set up this inflammation we talked about, and that healing process lays down fibrosis. And this is usually can be a positive feedback loop that, if unchecked, ultimately leads to cirrhosis. And cirrhosis, unfortunately, is a very prevalent worldwide. 112 million compensated cirrhotic patients, patients with cirrhosis around the world, and it leads to 1.3 million deaths per year. And the biomarker for chronic liver disease, fibrosis, and development of cirrhosis is the amount of fibrosis in the liver. Again, there are some qualitative features on ultrasound that you also see in CT and MRI that can help us diagnose frank cirrhosis: small size, coarse and heterogeneous echo texture, nodular contour, volume redistribution, and of course, evidence of portal hypertension. Now, I will say that if the findings are not definitive, don't call it cirrhosis. We had a slew of trainees calling any funny-looking liver as cirrhotic, and our poor hepatologists were inundated with patients who were non-cirrhotic. And so we have several macros in our template reports that go from a normal-looking liver all the way to a cirrhotic-appearing liver, with some intermediate language for dysmorphic liver or features of chronic liver disease, but not definitively cirrhosis. So I would recommend you use that variety of language, because we don't want to inundate our already busy hepatologists with non-cirrhotic patients. But what about the other direction? What if we see very subtle findings of chronic liver disease, such as in this patient with hepatitis C? I think on a busy day, I would have called this normal. Now, maybe Dr. Kennedy, with more experience than me, could see some subtle parenchymal coarsening, some very subtle contour nodularity, but I don't think I would blame anyone for calling this a normal-looking liver. Same on CT. I think if you're going fast on an ER case, you'd call this normal, but someone who's a little, slowing down and paying attention may see that the left lateral segment's a little bigger than the rest of the liver. The spleen may be a little chunky. But again, it'd be probably easy to say that this was normal appearing, but due to a insurance required liver biopsy, this patient had actually advanced fibrosis, and so therefore was enrolled in an HCC surveillance program and was disqualified from a certain medication. So that's why I think shear wave elastography for fibrosis assessment is really, really important. So let's step back and talk about what elastography is. Well, elastography is a measure of tissue stiffness, but there's different ways of performing it and reporting it. So first you have to talk about the source of compression. So it could be strain elastography, it could be transient elastography, or shear wave elastography. And then there's different expressions of that stiffness. There can be qualitative maps or strain ratios, or truly quantitative techniques that give you measures such as shear wave velocity in meters per second, or stiffness in kilopascals. And keep in mind that not all of the methods of elastography give you all of the outputs of stiffness. So we're going to predominantly focus on shear wave elastography today that gives us the quantitative outputs. And why is the quantitation so important? Well, it's because fibrosis quantification is so important. But as I said, the amount of fibrosis correlates with the various pathologic stages of liver disease, whether you're talking about the ISHEX score or the Medivir score. So it's very important to decision making. And of course, the gold standard again is liver biopsy, but we don't want to be doing liver biopsy on every patient at risk. So wouldn't it be nice to surveil patients without a 16 gauge needle being thrown into their liver? So fibrosis increases tissue stiffness, which is a resistance to compression. And since ultrasound elastography is a measure of tissue stiffness, we can use it as a biomarker for fibrosis. And again, we're measuring shear wave speed in meters per second. We can then convert that to tissue stiffness in kilopascals using the Young's modulus in this equation here. And I promise you, this is the only equation I have in my entire talk. Keep in mind that MR elastography actually uses the shear modulus to calculate KPA from its wavelength calculation. And the shear modulus and the Young's modulus are actually a factor of 3 difference. So when you look at the charts for ultrasound, the KPA cutoffs are 3 times that of the shear modulus cutoffs used for MR elastography. So just keep that in mind. So again, shear wave elastography is a quantitative technique. We're measuring shear wave velocity in meters per second. And to kind of give you a visual representation of what shear waves are in a soft tissue or stiff tissue, in soft tissue, shear waves travel very, very slowly, whereas in stiff tissues, shear waves travel very, very fast. So the stiffer the tissue, the more fibrosis, the faster the shear waves. And then the more normal tissues usually have very slow shear waves. So how do we generate these shear waves? Well, step 1 is you have to send in a push pulse. Sometimes it's called an ARFI pulse, so acoustic radiation force impulse. And this is the deposition of high amplitude acoustic energy focused into the tissues to basically perturb the tissues. I tell my residents this is like dropping a pebble in a pool of water. Your pebble is the push pulse, and the ripples on the top of the water are the shear waves. So if you're wanting to see a intensity map of what that looks like, it's a very, very high amplitude, very intense acoustic pulse focused into a small area, like dropping a rock onto a pool of water. And it's enough so that if you have this water tank experiment with a lure hanging in the water, it's enough acoustic energy to actually deflect that little weight hanging in the water. If you put the transducer up against your hand and you activate the elastography, you can actually feel a little bump in the palm of your hand. So if you want to measure shear waves in a little area here, the ARFI pulse actually comes down just lateral to that and generates the shear waves that then traverse that area of interest laterally. Again, so the shear waves are traveling lateral to your direction of your push pulse. And if you want to look again, see that in a diagram, if that's your push pulse in a phantom model, that's your shear wave traveling from left to right through the phantom after the push pulse is deposited on the left side of the phantom. And then we use the background B mode image to track the deflection of scatterers to estimate how fast those shear waves are traveling through tissue. So if you have, again, this little phantom diagram here, and these are the points at which you're visualizing the B mode speckle of liver, then you can kind of tell when the shear wave traverses the different areas, and you can calculate the time with which for which it takes the shear wave to go from point A, B, C, D, and E, and then calculate your shear wave speed from there. Elastography techniques in clinical ultrasound are now very, very common. They come by slightly different names and have different appearances and different implementations. So this is point elastography. It's a single point of measurement with a numeric output from 2 different vendors. So on screen left, you see a patient with a cirrhotic liver of 2.8 meters per second. Screen right, you have a patient with a normal liver with a velocity of 1.11 meters per second. Now, many vendors now have 2D elastography. This is a measurement of a larger area and providing a color map, which is kind of nice, kind of looks like a color Doppler box. There's different variations in the size and the coloring, but I like this because it gives me, colors are pretty. They're actually very useful when you're showing these in presentations or to clinicians or to patients. There's even little cine loops, which I'll show in a minute. But these color maps, I think, are very impactful for a patient. So fortunately, the engineers here were smart, and normal was blue and abnormal was red. And so you can show pictures like this, and it's easy to convey the severity of the liver disease. And then some vendors actually allow you to acquire little cine loops. Here's a normal patient, here's a cirrhotic patient. It gives you, again, a lot of information about the homogeneity or the heterogeneity of the process and the severity of the liver disease. Keep in mind, there are going to be some confounding factors. For those of you that read MR elastography, obviously there's going to be confounding factors that we have to exclude, because things like a recent meal, heart failure, acute hepatitis, biliary obstruction, or other infiltrative diseases can stiffen the liver. And so then when you calculate your shear wave speed and calculate the stiffness, if you're trying to use that as a biomarker for fibrosis, you end up overestimating the amount of fibrosis. The nice thing is if you do elastography in these situations and the values come out as normal, you've still excluded significant fibrosis, but you can't rule in fibrosis when you have these superimposed disease processes in play. Now, I get a lot of questions about cutoff values, and even though this kind of graph is available in MR elastography as well, you can see MR elastography and ultrasound elastography do very well in identifying patients that are normal or patients that are cirrhotic, but there's a lot of overlap in the middle. So different societies and different scientists have chosen different ways of handling this. One is you just pick the best cutoff value that separates the most numbers of patients. Sometimes you can choose a cutoff value that weights towards sensitivity or specificity of ruling in or out significant fibrosis. What the SRU, the Society of Radiologists and Ultrasound, have decided to do is to be honest with this overlap and instead provide kind of a likelihood impression of clinically significant fibrosis in this new term called compensated advanced chronic liver disease. This is a term now cropping up in hepatology literature, because as we go toward a situation where we're doing non-invasive testing, cirrhosis is actually a histologic diagnosis. So really, without a biopsy, we shouldn't actually be diagnosing cirrhosis. So patients at risk for HCC and eventual decompensation may be F3, F4 fibrosis, which kind of is lumped together in this now new global term of advanced chronic liver disease. So as you march down the chart from normal to elevated, you'll see the likelihood of compensated advanced chronic liver disease going from low probability, suggestive of, high probability, and basically diagnostic for, with superimposed portal hypertension. And this does cause some consternation among the hepatologists because they're used to seeing a fibrosis stage in their reports. But unfortunately, our non-invasive tests, if you're honest with the literature and honest with the data, can't accurately separate the intermediate levels of fibrosis. The FibroScan people do it, but their overlap is just as bad. MR elastography, same thing. So ultrasound, I think is actually leading the way in how to actually interpret these data accurately. So how does shear wave elastography perform in the literature? There have been several meta-analyses showing that 2D shear wave elastography in this case performs very well for identifying cirrhosis with an area under the curve of over 91%. Here's another meta-analysis showing of 82 studies, almost 15,000 patients, comparing different techniques. And you can see point shear elastography here performing just under MR elastography and significantly above FibroScan or VCTE, as it's called here. Here's a final meta-analysis of 44 studies, over 6,000 patients, again, comparing point shear elastography to MR elastography. And consistently, MR elastography does perform slightly better. But I will argue, is that slight increase in the area under the curve justification for not using shear elastography or trying to advocate for doing MR elastography in every patient with liver disease? And I would say no. Sometimes it's just good enough, right? When you're talking about population health and macroeconomics, making sure we're good stewards of our technology and utilizing each technology in the appropriate way, I think is one of the most important things we can do. So some ongoing challenges with elastography. There's still some intermanufacturer differences which we're working on. There's still some patients that when they come back, they should be scheduled on the same system because of that intermanufacturer variability. There is still some depth dependence, so choosing the same depth every time is important. And unfortunately, given the explosion of steatotic liver disease, this technique does perform poorly in obesity and hepatic steatosis. But for follow-up, again, using these biomarkers for follow-up for a patient, decreasing liver stiffness can show successful treatment. For patients with congenital heart disease, we can actually use elastography of the liver as a surrogate marker for right heart pressures, which is exciting. And there's even literature suggesting we can measure stiffness of the spleen and use that as a biomarker for the severity of portal hypertension. So I'm going to give you some case studies and wrap up with here in just a few minutes. So here's a 68-year-old woman with hepatitis C and a slightly elevated elastography value of 1.69 meters per second. If you look at the chart, this is just below the cutoff, falling in the low probability for advanced chronic liver disease. The patient is treated with all of our fancy new hepatitis C treatments, and there's now a decrease in stiffness from 1.69 to 1.2, and this indicates a response to therapy. Interestingly, in this patient, they also had a serum panel which predicted F4 fibrosis. So the hepatologists were confused as to why there was a discrepancy between shear wave elastography and their serum panel. So the patient went on to biopsy, and sure enough, stage 1 of 4 fibrosis. So in this case, the elastography won out. But again, we have to be worried about confounders. So here's a 53-year-old woman with severe alcohol abuse, comes to our ER with malnutrition, vitamin deficiency, and heart failure. Here's a chest X-ray showing the pulmonary edema and has ascites, and they thought this patient had decompensated cirrhosis. So out of the ER, requested elastography, and here we had predicted with a 2.4 meters per second or 17 kPa, advanced chronic liver disease with clinically significant portal hypertension. But this patient was treated with Lasix, steroids, and antibiotics. The LFTs improved, the chest X-ray cleared, and we repeated the elastography, and here we're now at less than 1.7 meters per second, which is low probability for advanced chronic liver disease. So all of that increased elevation in stiffness was probably due to fluid overload and right heart dysfunction in that patient. Now, there is some advanced post-processing we can do of our elastography measurements, and that's shear wave dispersion. There's also similar literature coming out with MR elastography as well, because elastography, how we practice it today, assumes an elastic property of tissues, meaning you push on a tissue and it pushes back with the same resistance. But most tissues are actually viscoelastic, which means you can push on them, but they don't push back at you the same rate because they're pliable and they move in different directions. So this comes in with a new model called the viscoelastic model, or what's known in physics as the Voigt model. Oh, I guess I lied to you. This is another equation, but not one you have to remember. But this is how simple the purely elastic model is, and this is how complicated the Voigt model is for estimating the viscoelastic properties of tissues. But there is some early literature in measuring shear wave dispersion, or that viscoelastic property of the tissues, and its correlation with inflammation, which gets into some of the other biomarkers from that NAFLD activity score, which is specifically the necroinflammatory grade. And so combining the shear wave dispersion with shear wave elastography could help us identify those at-risk MASH patients that are rapidly developing fibrosis. So in the future, I actually see us doing a sonographic liver biopsy where we're measuring attenuation, backscatter, speed of sound, shear wave dispersion, and shear wave speed for a mixed model assessment and detection of correlations and confounders for a more accurate assessment of what's going on. Let's see how that would work. Here's a 60-year-old woman with a history of liver disease. So this gets to Dr. Kennedy's complaint of all of her patients coming in with elevated LFTs. So how can ultrasound help? So we see this as a fatty liver, right? Increased echogenicity relative to the kidney, the diaphragm's blurred, we don't see a lot of the vessel walls, increased attenuation. We confirm that with our attenuation imaging of 0.64 decibels per centimeter per megahertz. So that's elevated, so mild to moderate steatosis. But then we also do elastography, and here we're reporting in 3.7 kilopascals, which by our chart is normal. So this patient probably has simple steatosis, and we don't need a whole lot of aggressive workup for this patient, just some risk factor modifications, get their diabetes under control, et cetera. But what about this patient? Also a very steatotic liver, lots of attenuation, don't see any vessel walls, can barely see the diaphragm. We confirmed that in this patient with that UDFF, that ultrasound-derived fat fraction, in this case 16%, so that would be at that mild to moderate steatosis cutoff. And then we do the fibrosis quantification, and it comes back in this range of 1.7 to 2.1 meters per second, or 9 to 13 kilopascals. And this is suggestive of chronic or compensated advanced chronic liver disease. So this is the patient that needs referral to GI and a possible liver biopsy. These are the patients we need to identify and catch them before they progress on to silent cirrhosis and present to our emergency departments with decompensation or a metastatic HCC, because they were, unbeknownst to them, at risk for MASH-related cirrhosis. And how do these multi-parametric assessments work? Well, in predicting NASH, as called in this paper still, in this small study of 132 patients, they used attenuation coefficient, shear wave elastography, and shear wave dispersion in a multivariate linear regression to predict inflammation with an area under the curve of 0.94. And in another patient predicting at-risk NASH, cross-validation study, again using several parameters, they were able to identify patients with at-risk fibrosis and inflammation with an area under the curve of 0.88. So again, this speaks to the fact that we need multiple biomarkers, just like we look at multiple serum values when we do blood tests, to come up with a more global picture of what's going on with the patient. And I think the future for radiology in general, but ultrasound specifically, is very bright when it comes to artificial intelligence. Because if you look at all of these things that artificial intelligence can help us with, whether it's the pre or post processing, the operator guidance, and the diagnosis, keep in mind that these various parameters can be done in real time for the sonographer. So as the sonographer is actually performing their scan, the AI algorithms can be working in real time to help them with some of these some of these parameters. And that's fairly unique to ultrasound because it's real-time imaging. Many of the AI-based tools for CT and MRI are post hoc. After the data is already acquired, the patient's already off the table, and you're just working on the imaging data you already have. So having this real-time feedback, whether it's to improve image quality or to improve inter-user variability, I think is a great future benefit to ultrasound. And there's actually been some artificial intelligence-based research in helping identify NAFLD and NASH. And there's just one paper I found recently using a 2D convolution neural network with the RF data and looking at attenuation and backscatter statistics correlating with MRI-PDFF. They had an area under the curve of 0.97, which I think is pretty dang good. So in conclusion, I hope I've conveyed to you that there's an increasing need for reliable biomarkers of chronic liver disease, particularly for fibrosis and fat. And addressing the MASLD crisis is going to require a multi-modality approach. I don't need to dig on MRI, but I have to fight, not fight, I have to stand my ground here at UT Southwestern because there are some fantastic MR advocates here. But if you think about it, just to do MRI-PDFF on every patient at risk in the United States, we would need just here in the US an additional 4,000 MRI units, or a 30% increase in MRI units just to screen and surveil patients with fatty liver disease. And if there's anyone on the call who cares about the environment, keep in mind that ultrasound has a 1% carbon footprint relative to MRI. So if you are also thinking about the global and environmental impact of medical imaging, choosing a modality that has the smallest carbon footprint is just yet another benefit. Some final conclusions here. There are multiple quantitative ultrasound techniques that do show promise, several now clinically available. Additional validation and guidance is forthcoming from several societies, and I really do see that the future state is a multi-parametric assessment, and likely with AI-based tools running on board. I know that was a fly through of a lot going on in liver and ultrasound, but hopefully it got you interested. And I'm happy to use the last few minutes here for any questions or comments.
Wow. I'm inspired. I actually feel like I do a terrible job on fatty liver. And I learned a lot, David. So thank you for that. Are there any questions from people online or in chat? I didn't see anything in the chat box because I have one or two.
I just wanted to say that kind of blew my mind. I mean, there's so much more we could do than we're doing. And as you were talking, I kept thinking, God, we got to have AI do this. So I was really happy that you came up at the end with that. I hate that they turned NASH to MASH. I've always said the diseases don't change, just the names. So, it's like, are you in the club? Do you know the new name?
Oh yeah, and it gets even more confusing because if you look at the European literature, they call it MAFLD. So instead of NAFLD, it's MAFLD, but ASLD went with MASLD, and the diagnostic criteria for NAFLD, MAFLD, and MASLD are actually slightly different. So now someone's trying to come up with a grading scheme. Is this a patient who has NAFLD as we used to know it, MAFLD, or MASLD? So I'm staying out of it. Obviously, the hepatologists need to figure it out, but just keep in mind that there's all kinds of terms floating around there now.
Wow.
So I learned so many new things, including I had no idea what a steradian is, and it is the area of a sphere equal to the radius squared. So I still don't know what a steradian is, but I assume it gets calculated automatically. But I'll change to Anne here, but thank you. I thought that was extraordinary. And for the residents listening, that was the best explanation I've ever heard for shear wave. I love that the pulse is the rock and the wave is the ripples. That's it perfectly. So thank you for that, David.
Sure.
One thing I've heard said, David, is that LIRADS is an all or nothing. Because at one point I thought, well, maybe we can do LIRADS and ultrasound, particularly with respect to these cases that, you have poor visualization. And I, again, heard, no, you can't do it in ultrasound. You have to do it across the board. Does that still hold?
Yes. So, well, I should say, if you talk to Claude Serlin, who's the godfather of LIRADS, he says you have to take the whole enchilada. So he does not advocate for using LIRADS piecemeal. It really is an ecosystem that is interlinked, and they flow into each other with very similar lexicons and management guidelines. So it really is, takes a lot of advocacy, but I think the benefits outweigh the challenges in adopting what admittedly can be perceived as a very complex system. But AASLD and OPTN are basically relinquishing the imaging diagnosis of HCC to the imagers. And then LIRADS, in response, has a lot of hepatology input and transplant input into the development of the recommendations. So, we rightly have said, okay, we'll adopt your recommendations for the various, LIRADS categories if you let us manage the definitions for imaging diagnosis. And so that's how the various societies and various parties have come together to influence these latest updates to LIRADS. And I didn't get to touch on treatment response assessment, but that is also both CT, MRI, and now contact lens ultrasound have undergone recent updates for how to manage post local regional therapy, and importantly, coming up with different systems for whether or not the local regional therapy was radiation or non-radiation based, because we now have evidence to show that the criteria are very different and way above the knowledge and expertise of AASLD and OPTN. So they were happy to relinquish definitions and management of post-treatment changes after a local regional therapy over to LIRADS. So LIRADS is now leading in this space, and it is working in partnership with these other societies and organizations.
Okay. Other questions from the audience? We have radio silence.
One popped up on my phone.
just
How do
okay.
you implement this into your clinical workflow, and does everybody get this? Selected patients get this? How do you use this?
LIRADS, fat, fibrosis.
No,
Yeah,
the fat.
Okay.
Oh, so we actually created there is a billing code for liver fat quantification now. So we've built out an order and we can charge for it. We have basically a liver ultrasound order that has order entry questions in it, and the providers can select whether it's just a normal liver, a liver with elasto, or a liver with elasto and fat quant. And almost every one of them is like, oh, I can do fat quant too? Yes, please. And so I read 9 of them yesterday.
Okay.
So we do allow the physicians to drive it. Obviously, when we got started, we were, just having the sonographers practice so they could learn how to do it, and we can learn to interpret the images, and we wouldn't report it. Then I started reporting it for free, just to kind of start to passively educate ordering providers. And then I had targeted discussions with several clinics who were always ordering ultrasound for fatty liver, and I'm like, well, would you like a number with that?
Right.
Like would you like fries with that? And of course all of them say yes. So it's had a great uptake, and we're doing maybe a dozen a day just since January 1st. So it's been great. I haven't had to push very hard because people like having the number, right? Just saying steatosis by ultrasound and it's not very helpful. But if you say steatosis, with mild, moderate, severe based off attenuation coefficients, or 17% based off of UDFF, and then they can come back in a year and see if that number's gone up or down, I think that's very powerful.
Do you find it gets abused, David? Because, for example, every person that comes into the hospital or the emergency room here who has any kind of abnormal LFT gets an automatic liver Doppler rule out portal vein thrombosis, even when they had a CT half an hour ago in the ER that shows a patent portal vein. And I spend my life calling up or telling the sonographers, tell them, no, the portal vein is patent. It actually says it in the CT report. So that's one of the things that I struggle with. I want to, expand our services, but at the same time, I can't double and quadruple my clinical volume.
Sure. We do fat quantification for outpatients, right? Okay. Especially even for elastography, we only offer it inpatient on a case-by-case basis, because oftentimes those patients are coming in with fluid overload. Maybe they have right heart failure or what have you. And so they have a lot of confounding factors that oftentimes we can't tease out. Now, as far as doing liver Doppler out of the emergency department with every patient, we actually have a policy written down and signed off by the chief medical officer of the hospital that if a CT scan or MRI shows a patent portal vein and a liver Doppler is being ordered, we can cancel it. So we took over the ability to cancel based off of a policy signed off by the CMO.
Interesting. Well, we'll talk more on our travels to other continents about this. And Jeff Alpin, my colleague in abdomen, just says he loves the idea of that policy, because yes, we do cancel it a lot of the time, but you end up having to call people and explain to them why they need it, and it just
same thing with hydronephrosis.
Oh God!
Ultrasound for hydronephrosis when they just had a CT scan. So that's in that same policy. So
yeah. I love it. Well, I know the CMO very well. Maybe I need to get with him. All right. Thank you. Thank you for your time. I know you've got to go back to work, and some of my colleagues do. I think I'm going to start in on the adult beverages here in Ireland shortly. And thank you again. You really have opened my eyes to many things about the liver. And yes, Paula, we need to do better.
Well, thank you for the opportunity. I really appreciate it. Next time in person, okay?
Absolutely.